Hello, I'm Bia Carlini, your instructor, and we are now in week 7 of the tobacco-related healthcare disparities course. Our module today is substance use disorders and tobacco. And we are really fortunate that for this module, we were able to bring an excellent outside speaker, thanks to our partnership with Northwest ATTC. ATTC stands for Addiction Technology Transfer Center. And Northwest ATTC is also located at the University of Washington, and their main goal is to train the addiction workforce. They provide online training, intensive technical assistance, and also science-based information to the current and future workforce in this area. And next. As a result of this partnership, we would really appreciate if after you see this module, you're gonna see in your inbox a survey. It takes like a minute to complete. And this is essential to help Northwest ATTC to continue to support programs like ours and continue offering their own program. It's not required for this course by any means, it's anonymous, but it would be extremely appreciated if you have the chance to respond. And now let me present our speaker. Next slide. I'm really honored and excited to have here today Dr. Kim Ridkler. She's a PhD MPH, a professor in the Department of Population Health at the University of Kansas. And she's the founder and director of You Can Quit, bedside tobacco treatment service for hospitalized patients. And this program, it's known nationwide, has a great reputation, and has treated over 20,000 patients since 2006. Dr. Richter also conducts pretty sophisticated, big NIH federally funded research on tobacco treatment, both in rural primary care and hospitals. I'm really happy to have her here. And Kim, thanks so much for coming. You are a great professional and also my friend.
Well, I'm really happy to be here, Bea, and thanks so much for inviting me to give this talk. I'm going to go ahead and advance to the next slide. And, you know, I think because of the opioid epidemic, I decided to focus it mainly on tobacco use and opioid dependence, although I will talk a little bit about the overlap in tobacco use and other substance use disorders. And this is really kind of my first love when I got into doing research in the area of tobacco treatment, tobacco dependence. I actually started working with methadone clinics. And so I was really happy to have an opportunity to kind of revisit this area. So my objectives today are to really talk about the prevalence and health consequences of tobacco use among people with opiate or opioid use disorder, OUD, what works to help them quit, and talk a little bit about harm reduction, and then what really needs to happen in terms of future research and practice. I'm going to rely very, very heavily on this brand new review paper by Cynthia Vlad, Julia Arnston, and Shadi Navi. Shadi's the senior author on this paper, and she's really at the forefront of research in this area now, and you'll see her name on a lot of different publications, and I've had the good fortune to publish with her a bit on this topic, and so I was really happy when this very, very current review came out, and I'm really using it as my kind of yellow brick road for this presentation, and I understand it's assigned for you to read, and it's a really great read. This is kind of old data, but we know from this landmark study in JAMA that people with mental illnesses consume over 40% of cigarettes smoked in the US, although they do not by a long shot constitute 40% of the population. And, you know, people with nicotine dependence actually fall within the spectrum of people with mental health disorders. So people forget about it, but, you know, really ICD-10, mental, behavioral, and neurodevelopmental disorders, includes people with behavioral disorders. and people with psychoactive substance use disorders and nicotine dependence. So we're really all part of one big family. And I really do think of tobacco use as a comorbidity for substance use disorders. So it's really important to think about that. People with tobacco use, with nicotine dependence, actually are within that whole spectrum. So that landmark paper laid out the prevalence of tobacco use by different major behavioral health issues, and really found that folks with substance use disorders had the highest prevalence of tobacco use. And that was a while ago, but that was about 70% of folks, and that's in that teal bar, were current smokers, as compared to people with no other substance use or mental illness, having at that time a tobacco use prevalence of about 22.5%. But really, folks with substance use disorders kind of topped out the prevalence in terms of tobacco use. And I was inspired by this study to do a similar study that focused on tobacco use among people, focused on people with substance use disorders. So I even sort of narrowed the lens in even more closely to look at the prevalence of tobacco use among people with a variety of substance use disorders. And you can see people with who use marijuana, who current marijuana users in the past 30 days, had sort of the lowest prevalence at 70%, which is not low at all, but the lowest among people with substance use disorders. And again, people who used heroin at the time, and this was in relying on data from the late 1900s, so like 97, 98, 99, they had a tobacco use prevalence of 88%. So almost everybody used tobacco. And we've known from research conducted since then, it's a very recent study from Andrea Weinberger et al., that when you look at rates of tobacco use, if you look at the bars on your right, the lines with the square box points, you'll see that's the prevalence of people without any other substance use disorder. And that's chugging along at about 20% over all these years from 2002 to 2014. Up above that is the line with the diamonds on it. And that is the prevalence of tobacco use among people with substance use disorders. And it's basically 3 times that of tobacco use in the general population. And although it looks like it might be trending downwards a tiny bit, when you adjust for things like age, race and ethnicity, and income and marital status, the rates of tobacco use among people with no other substance use disorder, that 20% rate, is actually trending downwards significantly. But the rates of tobacco use among people with a substance use disorder, the upper lines are actually significantly higher. So actually, the rates of tobacco use, if anything, are slightly increasing over the last, almost 2 decades for people with substance use disorders, which is definitely going in the wrong direction. So basically, we consider tobacco use, the tobacco use disparity is actually widening for people with substance use disorders. So we know that tobacco use, cigarette smoking, is also associated with prescription opioid abuse. So we don't know whether, people start misusing opioids for one reason or another, and then start using tobacco, or vice versa. But we do know that daily smokers are 5 times more likely to report past year non-medical prescription opioid use than people who never smoked. And we know that people with chronic pain who are actually taking opioids properly as they're prescribed are nearly twice as likely to smoke. And there are also links between tobacco use and pain and chronic pain, because there may be some analgesic effects of using tobacco. So we know that even prescription opioid use and misuse kind of go hand in hand with tobacco use. So what are the consequences of tobacco use among people with opioid use disorders? Tobacco is really the leading cause of death. And there's one study that tracked people over a 24-year period, people who had been in drug treatment, and people who continued to use tobacco were 4 times higher than people who had never smoked or managed to quit during that time frame. They were 4 times more likely to die. So even within people who have a history of substance use disorder, people who continue to use tobacco are at much higher risk of dying early. We know that continuing tobacco use increases risks for relapsing to opioid use. And among pregnant people with opioid use disorder who are in treatment, tobacco use is associated with lower birth weight and worse neonatal abstinence syndrome. So there are quite a few really bad consequences of using tobacco use among people with opioid use disorder. We know that smoking does threaten recovery, and that quitting tobacco use actually promotes it. So in addition to the adverse kind of health outcomes, we know that if you continue to smoke, it's going to threaten your recovery, as I mentioned in the former slide. And if you're able to quit, it actually increases your odds of being able to stay drug-free. So there was a national epidemiological study that found that tobacco use initiation or continuation increases the risk of relapse to substance use disorders. I'm going to zero in on that in a minute, or actually in a follow-up study to that. And there was a meta-analysis done by Jody Prochaska and others of 19 randomized controlled trials, and they found that people who were able to quit smoking while they were in treatment for substance use, they were 25% more likely to be abstinent from their other drug of abuse. There was a really nice 175-person study that was conducted among methadone patients, and they did periodic drug screens. And so they were able to look on a week-by-week basis whether people were abstinent from tobacco when they were trying to quit and what their other drug use was. And they found that people in the smoking cessation study, when they were able to stay abstinent from tobacco, they were more likely to have drug-free urines from other illicit substances. This, I think, is a really great study because those other studies, for the most part, were conducted among people who were in some kind of a formal drug treatment. But this was a prospective community study of people with substance use disorders. And it was conducted over a couple of years, and they had a survey in year 1, and that is over on your left as you look at it. And then they conducted surveys among people 3 years later, and they got people who had a history of substance use. And they were looking at how they did over time in terms of their substance use. And fortunately, they assessed tobacco use as well. And they found among people who were non-smokers at the start of the study in year 1, the people who started smoking cigarettes in between year 1 and year 3 were less likely in year 3 to be completely drug-free, and they were more likely to have relapsed to abuse or dependence. So that's among non-smokers who started smoking. They were more likely to less likely to be drug-free, more likely to relapse. Among people who were smokers in year 1, if they continued smoking across the follow-up period, then they were less likely to be completely drug-free, and they were more likely to relapse or to their abuse or dependence. So if you don't start, or if you stop smoking, then you're going to have better outcomes than if you start or continue smoking, if you've got a history of substance use disorder. So I think that's a really great study, and these are not even people who are engaged in treatment at all. So, to top that off, most smokers with opioid use disorders really want to quit. They consistently report that they're interested and motivated to quit. And really their rates are very similar to rates of readiness to quit in the general population. And most people have already tried to quit smoking many times, and some have been able to quit for, a month, 6 months, even years. And attempts to quit smoking is a great predictor of future cessation. So people are interested in quitting, and they're actively engaging in trying to quit. Now, why would someone who has a history of sometimes illicit drug use, opioid use, why are they interested in quitting tobacco? Some people will say they've got bigger fish to fry. Well, there's very good reasons. These are some quotes from a qualitative study that I and other folks did right around 2000, so almost 20 years ago. And one person, this was a young man, I still remember his face. He said, I see my grandparents, my relatives, they've all got emphysema because they all smoked. They can't go to the mall, they can't go to dinner, and I think, why should I keep doing this stuff to me? He didn't say stuff. And he was in methadone treatment, stable in methadone treatment, pretty young guy. This is an older person. He was another man, a father of children. And he said, I don't want to get hurt, and I don't want to hurt anyone else. I have 3 babies. I'm falling asleep with cigarettes in my hand. And that is the reality that I need to stop smoking. He was afraid he was going to burn his apartment down with his children. So these are very serious reasons to quit. People are quitting for their health, for what they see that tobacco's done to their family members, and also for their children. Unfortunately, most formal drug treatment programs fail to provide evidence-based care for tobacco treatment. There have been a number of surveys of substance use disorder and opioid use disorder treatment programs. And this is from, this is a range cutting across a number of these studies, some of which I did or participated in as a co-author. Really, 18 to 45% of programs say that they provide cessation counseling, so less than half. And less than almost 10% to 1 in 3 provide some kind of cessation pharmacotherapy. But when you ask them, well, in the past 30 days, how many people, in your drug treatment facility did you actually treat for tobacco use? It's very, very few. So they'll say they provide these services, but when you ask them, how many people have you provided them to? They're very, very low. So what does work to help people with opioid use disorders quit using tobacco? We've got to, place some caveats around this next section, because people with opioid use disorders are often excluded from efficacy trials for smoking cessation. Many people with substance use disorders as a whole are not included in clinical trials. So, in fact, when you look at quit smoking studies and who actually participates in studies of new medications, new counseling approaches, etc., they really only generalize to about 50% of tobacco users. People who participate in these trials are kind of select people. And people with opioid use disorders are not really represented in the general body of research in smoking cessation. Even within studies who include people with substance use disorder, they exclude people who are on opioid agonist treatment, that is, people in methadone and buprenorphine. Very often these folks are excluded from trials that are conducted within substance use treatment facilities. So even studies that are conducted within the population of people with opioid use disorders, they still miss a lot of people with those disorders. They include mainly people who are in some kind of formal opioid use disorder treatment, like methadone or buprenorphine. And they usually select smokers who say, I'm ready to quit within the next 2 weeks or 30 days. And they usually select people who are daily smokers. And nearly 1 in 3 Americans are non-daily smokers. And racial and ethnic minorities, folks, African Americans, Latinx folks, in general are lighter smokers, so they're going to be underrepresented in these studies. So these trials that are even conducted among people with opioid use disorder will be excluding people who aren't in formal treatment or who are getting treatment through their medical care provider in the case of buprenorphine treatment, or they're people who are not sure that they want to quit, so they're not included in the studies, or who don't smoke on a daily basis. Now, before we get to quit rates and efficacy and stuff like that, I do want to point out that smokers with opioid use disorders, they face a lot of barriers to cessation when they try to quit on their own. So there are the nicotine opioid interactions that get in their way. Nicotine may make opioids more pleasurable, so you just might feel the onset of your opioid a little bit more pleasurably if you're smoking. When you change opioid dose, it actually tracks with changes in cigarettes per day. So, so the more opioid you're using, like if you're titrating up in a methadone clinic, you'll actually be smoking more cigarettes per day. So it might make it harder to quit. And nicotine may combat the sedation that goes along with getting habituated into opioid treatment. So it actually, that might make it more difficult to stop smoking cigarettes. There's also systemic and treatment-based issues. So addiction treatment rarely addresses tobacco. I've already covered some of that data. There may be a lack of access to cessation medications or coverage for formal counseling. People may not have insurance. And there also may be pro-smoking social norms among staff. We know that there's still a pretty high rate of tobacco use among staff in methadone and buprenorphine treatment programs. So we know that staff who smoke are much less likely to bring up tobacco cessation among people that they treat. And then there are individual level barriers. People have a very high burden of chronic disease and chronic pain, which might work against their desire or ability to quit smoking. People have psychiatric comorbidities, and they've got social networks with lots of smokers, so it just makes it hard to avoid those people and places where smoking occurs. So patients may be overwhelmed at even the thought of trying to quit using tobacco. So this is a great quote from that review paper by Vlad et al. The high burden of chronic medical illness among people with opioid use disorders may limit utilization of evidence-based cessation pharmacotherapy by increasing the pill burden, I've got to take one more medication, increasing the side effects. So they're taking multiple drugs at the same time, and people don't know what to attribute different side effects to, and often they're willing to blame it on their cessation medication. And through, risk perceptions that prioritize their other medical concerns. I've got to control my hypertension. I don't know that I've got time to really worry about quitting smoking right now. So people may just be overwhelmed. And, going into that whole equation, that balance of should I quit or should I not quit, are the fact that staff and administrators in formal treatment programs, and maybe even out in the community in medical facilities who are treating opioid use disorder, they may not be supportive. Now, this is from a qualitative study that we conducted among staff of substance use treatment facilities. And one client said, unless you ask them, that's the staff, about addressing the tobacco situation, then they will address it. But if you don't say anything, that they would never say anything about it. So it's kind of a don't ask, don't tell situation where staff are not going to proactively address tobacco use among their clients, even if they're very stable in treatment. Now, a staff member had to, sort of went along with that, said, yeah, if some client was dying from emphysema or something, it might end up on the treatment plan. So the staff are not bringing it up. So what does work in spite of all of these barriers that are sort of stacked up against proactively addressing tobacco use among people with opioid use disorders? What really works? We know from epidemiological study, this is from these first few pieces of data are from a study that I did that sort of got me into research in this area. We knew that a small percentage of people with opioid use disorder who were in methadone treatment were former smokers. And I took from that it is possible to quit. I doubt that these people started smoking and then stopped smoking and then became people with opioid use disorder. You know, I got to believe that some concurrent tobacco and drug use was going on, that they didn't quit smoking before they had opioid use disorder, and that people with opioid use disorder are able to quit smoking. And we know from that same survey that people were making really frequent quit attempts and able to quit for periods of time, but most are not able to quit, you know, permanently, just about 1 out of 10. Now, in clinical trials, this is the take-home message from the Vlad and Arnsten and Navi review paper. These are their lessons learned. They said that, look, when we look across the studies that we reviewed, nobody in the control groups quit smoking. So we know that treatment is critical to get people to quit smoking over the long run. Also, it's pretty clear that low-intensity behavioral alone interventions aren't going to work. And we know that even if you've got evidence-based interventions that include behavioral intervention and medications, these are going to yield very modest quit rates. So that's the take-home message. No treatment is not going to get you anywhere. Low-intensity treatment really isn't going to help people quit for the long run. And what we need to do is bring both arms of evidence-based care, medications, and counseling, and understand that we're going to get modest quit rates. So I'm going to walk through this a little bit. Okay, so low-intensity interventions, and this means brief counseling or brief counseling plus a quit line referral. Basically, all these studies had 0% quit rates and follow-ups. And so these involve brief interventions that were based on 5 A's, referral to quit line, and motivational interviewing approaches achieved very modest quit rates. And these were not significant over any comparison groups. So why doesn't low intensity work? It does work for the general population. You get lower quit rates with the lower intensity interventions, but you do get some quit rates. But in this group of folks, you know, maybe the low intensity interventions are too generic. They don't address the many specific barriers to cessation for people with opioid use disorders. Maybe people have unstable telephone access. It doesn't address the physical dependence that pairing behavioral intervention with medications would. And it appears that across the studies that use this approach, the adherence to in-person therapy was really low. So this is the experience of a methadone user and what her smoking kind of does for her. She says, the experience of smoking for me when I'm jonesing and I take in that first hit, it's like scratching an itch. It's like taking a drink on a really thirsty day. It's like taking a breath of air when you've had your head underwater and you pop back up. So, you know, tobacco use is incredibly important to people. And a low intensity intervention probably isn't addressing anything near what it needs to in order to help people quit. Contingency management involves financial or other incentives that are contingent on abstinence, on quitting. So there were 2 large trials that used contingency management for helping people quit smoking. And they did have significantly higher quit rates compared to control groups at the end of 12 weeks of treatment. But after the contingency management was over, people quickly relapsed to smoking. So we know that contingency management helps people achieve initial abstinence, which is important. But we need to find ways to extend that abstinence. So this is a great way to go to help people achieve that initial abstinence, but we need more. How about medications for smokers with opioid use disorder? In study arms without medication, cessation is negligible, kind of reiterating what I talked about before. Nicotine replacement therapies, that's NRT, achieves quit rates about half those found in the general population, around 10% at the end of treatment. And then people rapidly relapse when the pharmacotherapy stops. Now, high dose combination and extended NRT achieves about 75% lower quit rates than they achieve in the general population of smokers. So solo NRT is going to get you about half the quit rates you'd expect among people who don't have opioid use disorder. And when you hit it really hard with either extended or high dose or combo NRT, you're going to get less of an effect than you would with people without OUD. Doesn't mean it doesn't work. It just means that it doesn't work as well as among people without opioid use disorders. For bupropion and varenicline, the story is a little different. There's limited data for bupropion. I and colleagues conducted a small uncontrolled pilot study of bupropion plus gum and motivational interviewing, and we got 14% biochemically verified quit rates at 6 months, and I kicked myself on a probably monthly basis now for not having a control group, because it was a great intervention, very much appreciated by patients, and I thought it was highly successful, and I could never get funded to do the follow-up large study of this intervention. Long story there. But there aren't many other studies of bupropion, and their findings were mixed. Now with varenicline, the findings have been mixed so far, and with a rapid return to smoking at end of treatment. So Shadi Navi conducted a placebo-controlled trial, and she found that about 10% who got varenicline were quit at the end of treatment. The people who got placebo, none of them quit. And she found, importantly, that there were no psychiatric or cardiac serious adverse events from the use of varenicline, but people did relapse once treatment ended. Now, and Mike Stein compared varenicline with combination NRT and got single-digit quit rates in both study arms. And both found that medication adherence was a problem in varenicline trials. So how to get people to adhere is a big issue. It's an issue in all populations, but it is also an issue in this population. So why such low rates, even with really strong pharmacotherapy assisted interventions among people with opioid use disorders? You know, maybe they got limited treatment provision. It had an end to it, so people couldn't turn around and help people try to quit again once they relapsed. People might have gotten very limited social support from family and friends because their social networks are heavily peppered with smokers. Again, and this is really short-term one-shot treatment. And there was poor adherence to the treatments. And there are those opioid nicotine interactions that I mentioned earlier. So it may be that people sort of lost the stimulating effect of their smoking and felt the loss of that and started feeling more sedated, for example, with their opioid therapy. And that might have helped tip the balance for them to relapse. So, you know, I just think we need to take away from this the fact that quitting is hard. Okay, this is a quote from a woman who managed to quit on her own. And this was collected in 2002, 20 odd years ago. And this is what she did. Okay, this is her treatment plan. She said, I avoided the boats. I concentrated on the breathing. It seems that whenever I got that serious nagging want or need for a cigarette, I'd just take 2 or 3 breaths and it'd go away. The only thing I ever really correlated with smoking was drinking. I already put the beer in there. If I just avoided the bars and the boats, I figured I had it made. Well, and people that smoked. So I bought a box of Nicoderms to help with that craving and the big breath. And I'm not saying it was a walk in the park at all. So there goes my punchline. Okay, I'm going to put that away. So can you guys imagine why she said she needed to avoid the boats? She was a gambler, and in Kansas City at the time, you couldn't have a casino unless it was a boat. And so what they did was make these non-seaworthy concrete buildings that were erected over water, and that's where people went to gamble. So what she was really talking about was avoiding the casino. So for her, it's this. She didn't even talk about some of the other barriers we talked about, except for maybe friends that smoked, alcohol, etc. But it was very difficult for her to do. And, you know, so our challenge is really to figure out how to beat this sort of multi-component intervention that this woman had to do for herself. So we know in the general population that overall, with just one round of treatment for tobacco dependence, that you'll get a certain level of quit rates. And so this is data from meta-analyses, and they're summarizing the kind of quit rates you get with one round of treatment of different levels of intensity. So for quitline, you'll get about 13% of people quit at 6 to 12 months. But down at the bottom, if you use combo pharmacotherapy like nicotine patch and gum, plus counseling, you'll get over 1 in 3 quit at 6 to 12 months. Okay, so that's really either varenicline plus counseling or combination pharmacotherapy and counseling are really the gold standards. But you got to remember that that's based on clinical trials where we say, hey, we're going to treat people and then look later and see how they did. It doesn't really take into account the fact that drug dependence and tobacco use disorder, nicotine dependence is a drug dependence, is a chronic medical illness. And there are relapses that go along with any chronic medical illness, including asthma, hypertension, diabetes. And so we need to provide longitudinal chronic care. And when we do that, we don't even know what kind of quit rates we would get if we treated tobacco use disorder like other chronic health conditions or addictions. This chart at the right gives us the lowest bar on what we do when we just give somebody one shot at treatment. But if we were to check up with people and offer a change in treatment or adding on things, if they're not able to quit completely or if they relapsed, we don't know what kind of quit rates we could achieve. So that's really, I think, the main challenge that we need to face is we need to really get this integrated into people's ongoing care for addictions and for medical issues. Okay, now I've got one slide on harm reduction. So, you know, harm reduction is a very important approach for basically reducing harm for people and keeping them alive, keeping them as safe as possible, short of trying to get people abstinent from whatever drug they're using. And, you know, in tobacco treatment, it's often been framed of reducing tobacco toxin exposure. So what if we could reduce the addictiveness of cigarettes or reduce the toxicity of cigarette, reduce the harmfulness of tobacco products? Could we help people reduce some of the harm from their tobacco use? Another thing one could think about is reducing the harmful consequences of tobacco use, like if there was some way to treat the health consequences of tobacco use and minimize those. And one major player on the scene that people believe is going to be a harm reduction tool down the road, if not now, are electronic nicotine delivery systems or e-cigarettes. But studies among people with opioid use disorder have found that there are people who are using e-cigarettes, but they tend not to quit or switch completely from the combustible cigarettes over to the e-cigarettes. So they end up stuck using both. So right now, the jury's really out on whether these things could be a harm reduction strategy for people, because they tend to keep using the combustible cigarettes and experiencing all the harm from smoking cigarettes. But it is something that is very much of interest, and we need to do more research on. Okay, so how about future research? Okay, so there are some ongoing trials. One is examining, placebo-controlled trial is testing the effects of nicotine nasal spray and varenicline on tobacco use during the peak methadone effect. And I think they based this on a study that I and some colleagues did at KU, where we looked at people in methadone treatment and their patterns of tobacco use. And it looked like their peak tobacco use on a daily basis happened right after they took their methadone. That is, as the methadone was coming on, and they might have been feeling a little bit sedated just right after they took their dose. And they perhaps were using cigarettes to help them stay awake or perk up a little bit. There's one trial that's actually looking at varenicline, probably taken on a 2 times a day regular standard treatment, but nasal spray to counteract the sedating effects of their methadone dose. So that's really unique and is definitely designed to combat some of the nicotine opioid effects, and very, very interesting. So it'll be great to see what they come up with. And Dr. Shadi Navi is doing a study of directly observed varenicline versus self-administered treatment on adherence to really try to get at the adherence issue for varenicline. There are lots of future research questions out there. When is the best time to introduce tobacco treatment? Is it right when people sort of get into treatment for opioid use disorders, or is it better to wait? How might tobacco treatment for people with opioid use disorder differ from those in treatment for other substance use? Like, are there shades of difference? And we have some examples of what that might look like in the studies that I mentioned above. Is tobacco use or ability to quit different by type of opioid used? So we've got non-medical use of prescription opioids versus heroin versus other kinds of opioids. So are there differences within opioid use? And, you know, what is the interaction of pain, tobacco, and opioid use? I think this is a huge question, and one it would be really lovely to see some future studies on. There are more questions. So, you know, how do you engage smokers who are not quite ready to quit? And this is a question for the entire field of tobacco treatment. A lot of tobacco users aren't ready to say, I'm ready to quit right now. And a lot of our treatments are designed for people who are ready to set a quit date. So what do we do for them? How can we enhance the efficacy of existing treatments? You know, I offered one way to go at it, which is treating it like a chronic relapsing condition and doing really longitudinal dynamic care, but there may be other ways to do that. Will increasing adherence to tobacco treatment, like counseling and medications, increase abstinence? And that's a study that Dr. Navi's doing that I mentioned earlier. And how can programs implement and sustain tobacco treatment? That's a bigger question of, once we get effective treatments, how are we going to get that integrated into people's care systems? So this is actually a quote that I stole from the Behavioral Council, and they focus on chronic diseases and people with behavioral health disorders. And they say that it's important to meet people where they are, but not to leave them there. So I feel like things that we can implement right away include proactively bringing up tobacco use and asking interest in quitting among clients, giving people accurate information about the risks of tobacco use, and letting people know about the benefits of quitting, including the impact on their ability to stay abstinent from their other drug abuse, and normalizing that it's hard to quit, but also providing evidence-based treatment with varenicline or combination NRT preferably. So I feel that treatment is ethical. Treating tobacco use disorder in conjunction with treating opioid use disorders, it's important to do. I think we must do no harm. We know if people don't get help that most of them will continue to use tobacco, and a lot of them will die from tobacco-related illnesses. Not addressing tobacco will cause more harm than addressing it. People should offer, not mandate, tobacco treatment, and just keep it on smoking cessation on the problem list, motivate every few months using people's personal risks and discussing their barriers. Don't make people beg for treatment, and let the smoker decide the timing. And really, you know, a wellness philosophy that I believe behavioral health has been moving toward involves assisting people to lead meaningful lives in their communities and keeping up with the community and promoting behaviors that lead to health. So I really appreciate your attention and your interest. My email is below there, and please feel free to reach out and contact me. You will see that a lot of the slides were based on that review paper by Vlad, Arnsten, and Navi. So I would strongly encourage you to read that carefully. It's a really great paper. Have a great day.
Thank you, Kim. I'm gonna end the recording now. Thank you so much.